So unfortunately, sometimes we can't prevent wounds, and so now I'm going to talk to you a little bit about how to actually manage the wound itself. And typically one of the easiest ways to remember the different steps of this is to use an acronym called MEASURE. So if you look at the left-hand side of that PowerPoint, you'll see the bolding of the letters MEASURE, which is measure, and we're going to talk about each of those areas. Okay, so how do you measure wounds? Well, generally speaking, what I would suggest is that we should, to make it standard, you need to standardize a process within your facility so that everybody's doing the same thing. Otherwise, you can get some very confused individuals when wounds aren't the same size, or huge discrepancies from week to week. So essentially, the longest part of that wound is the length, wherever it lies in space, and then the widest area is, or the longest area perpendicular to that, is the width. So I'll show you a wound in a minute to kind of try to give you a better example of that. But essentially what you want is that standardization. We typically don't go head to toe. We use length for the longest and width for the second longest axis, but it has to be perpendicular. So if we were to measure that wound, you can see it runs down the length of her leg. So the longest axis of that wound happens to be head to toe. That's not very often that you're going to see that, or it isn't routinely that way. So that is the length. It actually does go head to toe. The width would be the widest of those two axes. So probably the bottom wound of those two, you see it kind of elongates. It goes almost, it's quite elliptical in shape. So the bottom of that, I'm going to say to you, what you do is you measure the two widest points and you decide which one is the longest. And then that's your second measurement, okay? In this instance, you'll see there's a second wound on that limb. You can measure it if you like, but measure it as a second wound. But essentially, if you get that biggest wound down in size, that's going to be your marker. I don't tend to ask people to measure multiples because it just gets complicated. So do you measure depth? I hope you do. Essentially, the depth is the deepest part of the wound, wherever it is. And essentially, what you need to measure that is a sterile Q-tip. So you would put your Q-tip into the deepest section. You would put your thumb at skin level. You would pull it out and you would measure the depth of that Q-tip. So how far it went into that space. And why would depth be essential? Well, if you think about it, where is tissue going to fill in? When there's space below, the tissue comes up from the bottom. You're not going to, unless you've got, you're going to have an issue if it closes over prematurely, and we're going to talk about that later. Essentially, what you want is a fill from the bottom, and then gradually it'll come in from the sides as well. But if you don't measure the depth, how do you know if you're getting anything going forward? How do you know if you're winning the war? So really an important component of measurement that we need to include. So the second letter in measure is exudate, or E. So essentially what it is you're measuring the type. And I don't honestly care what terminology you use. It used to be that we had a red, yellow, black was some of our criteria, and that's fine. Describe what you're seeing. What you need to do is the person that's coming behind you, that's reviewing that documentation, has to be able to tell if something's different. That's what they're looking for. So if it's pink drainage today and it's green tomorrow, that's a problem, right? So that's what you're trying to identify. Our standards are serous, serosanguinous, purulent, but whatever works for you guys, whatever communicates what you need to communicate. Amounts, basically we're going to look at small, where the dressing is less than 25% saturated and the wound bed is moist. If it's a moderate amount, that dressing is 50 to 75% saturated, and again, the bed is moist. The difference is when you get to large, and you have a large or greater than 75% of that dressing saturated, but the wound bed is still wet. So I'm going to give you an example just to get you to think about what this really means. If I had 2 2x2s on a wound, and they were less than 25% saturated, that's a small amount of drainage. But if I had 4 4x4s and 2 ABDs on that wound, and they were 25% saturated. That's not a small amount. So when you think about that, you need to think about what is the amount of dressing material that's required to contain that amount of exudate as well. Does that make sense? You know, it is common sense, but anyway. Maceration, so we think about moisture, we think about exudate, we need to think about what is that tissue looking like around. And remember I mentioned earlier that even just putting moist cloths on intact skin could cause overgrowth of bacteria. Wet skin is very prone to infection. So if things are too wet, and you're going to have much more likelihood of bacterial overgrowth. And maceration is basically that wet, white, waxy looking tissue. And if any of you have ever seen that, and you took a Q-tip and you ran it over the top of the wound, it literally comes off. It's very, very damaged. It's basically dead tissue. And essentially, when you see maceration, you've got to think of, am I doing the best job I could of absorbing that drainage? In that wound exudate, there are enzymes. Those enzymes are non-selective. They're proteases, and they eat tissue, irregardless of what the source of it is. So when we put dressings on something, we need to identify that the dressing's actually absorbing the exudate. If it's not, and it's sitting on the skin, we will get maceration because those enzymes are actually digesting the tissue. So when you see wet, white tissue, think about dressings, okay? So we want to describe tissue, and that's important because we need to identify when things are actually progressing, right? So when you think about tissue, we need to talk about, is it granulation tissue? Is that nice pink, reddish bed of vascular tissue? Or is it slough? And I'm going to show you some pictures to try and demonstrate some of that, so we're using common language. Are the edges of the wound attached or unattached? If they're undermined, they're unattached. Is that peri-wound skin red or macerated or bruised or calloused? We need to describe that. Why would we be doing all of that? Well, essentially, we're trying to identify, is this a healthy wound? Are we seeing nice red, healthy granulation tissue? Are we identifying that there's an unattached area where we may have issues with shear and friction that we need to address? Is the skin around that wound healthy? If it's not, is that likely to cause other types of surrounding breakdown and other infections like fungal infections? And your description is helping your partners to identify that you're getting it right. That redness around the wound, is that infection? Like, what is going on, right? And when you see redness around something, measure it. I challenge you to measure it, because then if somebody else comes back and it's advancing, you probably do have infection. So some examples of tissue are, this is slough. Slough is that yellow or gray-green tissue that sits loose on a wound. It's stringy. If you take a forceps from one of our lovely disposable dressing kits and you try to grab a hold of it, hopefully it works, and you can pull it up and it's stringy, that's slough. If it's attached, it's not. It's actually a scaffold for new tissue growth. It's fibrin, so do not disturb. If it's well adhered, nice yellow flat tissue, not stringy, leave it alone. You'll get new tissue growing on it. But if it's that lovely loose yellow or gray, it needs to come off. So eschar is black or gray. It can be wet. If it's wet, it's going to be really smelly. So it doesn't necessarily mean it's infected. It means it's got dead tissue in it. Or it can be dry and hard, and often it's firmly attached. When you see redness around black, dry tissue, are you thinking about infection? Be careful. Be very careful. Black necrotic tissue is loaded with bacteria. If it's dry and well attached and this person has little potential to heal because it's on a foot with no blood flow, leave it alone. The redness around is a response to the foreign body and bacterial load. It is not infected. And if we give that individual antibiotics over and over, which does happen, what we do is create resistance. So then if you see that, you have to identify, measure it. Is the edge advancing? Is the person feeling septic? Are they ill? Is there fever? Is there increased pain? And you look for the other things that might be indicating that there's a problem, but don't assume anything. So I want to mention pain because I imagine, I've shown you some pictures and I'm going to show you more. But do they think they have pain? And I'm going to challenge you a little bit about that, because sometimes we often notice if they have pain during a dressing change, but do we actually notice when they have pain in between? And pain is related to stress. Stress increases risk of infection and reduces the likelihood of healing. So it's really important to address it. And don't assume that because they don't complain there is no pain. If you have a pressure ulcer in a quad and they're sitting on an IT that's got a big hole hole in it, often what they'll do is their pain will be reflected in a headache. They get referred pain all the time. They get reflective pain. So it's not necessarily in the area of injury in some individuals with neuropathic changes. So we need to really think about that and look at that. So one example of a pain tool here is our standard 0 to 10 scale that most of us have used in the past. So where 0 is no pain and 10 is the worst pain ever. But if you're dealing in long-term care clientele that have cognitive impairment, this is not a particularly useful scale, as most of you probably know. And there actually is a pain website that's being formulated on the Saskatoon Health Region Infonet. I'm not positive if it's up yet or not, but hopefully it will be soon. And one of the things that they advocate for, or that we have advocated for in medicine, is the use of something called a pain-ad scale. And that's spelled PAINAD, and it's really useful in dementia patients because what it measures is things like grimacing and pulling away and all of those other indicators that when they can't respond to us. So we mentioned undermining earlier, and I want you to think about, when I said to you, what is it? Well, remember I mentioned it's in relation to shear. So if you have an individual that's being transferred using on a bed, so they slide to the edge, or they're using a sliding board, and you're undermining. So when you measure undermining, you measure it head to toe. So 12 o'clock is your head, 6 o'clock is your feet, this is 3, and this is 9. So you're looking at an anatomical clock, and what you're trying to determine, you're describing the undermining according to that clock. So if I'm on a transfer board and I'm sliding towards what in my mind here is 3 o'clock, because my 12 is here, the undermining is typically at 9. Does that make sense? So what you're looking for is it's where you're sliding towards, where the drag is. So if you've got somebody who's using a sliding board transfer that's undermining at 9 o'clock, what you need to do is get your OT partner in there to review that transfer and somehow either remove that or find something better or somehow reduce the friction on the board. But somehow you need to look at undermining in relation to things like transfers, like positioning in beds, because until that undermining is dealt with, you're going to continue to re-traumatize that wound. And so it's the non-visible issue. So when you actually assess a wound for the first time that has depth, remember we talked about putting a Q-tip in it? Run that Q-tip around the edge. If those edges aren't attached, see if you can advance it gently underneath there to see if there's undermining. And when you do, measure the distance that is, because that needs to come in first before you will not get the rest of it to close until that comes in. That area traps a terrific amount of bacteria, and please don't pack it. If you put gauze packing under there, you increase pressure, and what are you doing? You're separating the edge. I usually actually use something like an intrasite gel underneath that edge. I put it in a sterile syringe with a blunt needle, and I actually inject that. Stops too rapid a closure, but it actually allows that to grow in. So you have to be really, really careful. You need to measure regularly, and hopefully you guys have some parameters that you're using for that. How do you know when things are improving? How often do you measure? I'm going to say every couple of weeks if it's a very chronic wound, so that you don't feel like you're, beating your head against the wall, and neither does your resident. But what do you document on? Do you have a wound assessment form that leads you through the process? You should. It's important so you and the client that you're looking after, a resident, know whether or not you're progressing. And I'll give you an example, and I hope you can visualize this well. These are 2 photos that 2 nurses, that a group of nurses brought into a workshop that I did, actually for CEDN. And they brought this picture in and they said to us, well, we're really frustrated, Donna, because these are, and they're fabulous pictures. They've written all those measurements down. And they said, this person's not getting any better. But if you look closely at those measurements, they actually were. I could see quite a couple of, a centimeter here and a centimeter there. The wounds cleaned up significantly, and they were actually winning the war. And when we sat and looked at that and said, I said, this is a fabulous job of doing, you know, all those measurements to say, you are getting it right. You're not doing a darn thing wrong. Carry on. And, you know, I don't know if it's closed yet, but tremendous amount of information in those photos. So you do need to measure in order to know if you're getting there. So how do you measure that wound? Well, we talked a little bit about cleansing with skin tears. So we're going to talk about cleansing pressure ulcers. Basically the same principles apply. You have exposed dermis or subcutaneous tissue. We need to be very careful that we don't traumatize wounds. So it's essential that we use the proper pounds per square inch irrigation pressure to clean. And so what that is that those dual top twist off 100 or 60 mil salines. There are some that are actually screwed off that now that you can get from some companies. Those have been actually identified in research to have the right PSI. And then you hold them 3 to 4 inches from the wound and you cleanse. And typically the recommendation in the pressure ulcer guidelines is 100 mils. It need a lot. The little pink minims are not a good option. The 15 mil pink minims are not designed for wound cleaning. They actually have way too much pressure. The narrower the barrel of something, the higher the pressure. It's not enough volume, and it has a potential to traumatize newly vascularizing tissue. So what solution? Use an isotonic solution. Saline is the best one, but if you're using C-Cleanse, that's fair. But if you can, we need to try and warm it up to at least room temperature. Remember I said cells stop dividing at 28 degrees? Room temperature is about 24. So what we used to advocate for in home care, and I can't say this too much now, but we used to try to warm it up. And I'm not going to tell you how to do that, but you have to be very, sometimes you can put it in the pocket of your uniform, carry it around close proximity to your body temperature. The more you warm it, the more likelihood you're going to actually reduce healing time. And in fact, when we started warming saline in home care, I was doing things like wound care audits. We actually, we warm it in the microwave for about 15 or 20 seconds with the lid off, and I know that everybody's going to go, shook it up, tested it on your arm, just like you do a baby bottle, and we had really improvements in healing time because we weren't cooling wounds off. We also extended wear time to also maintain thermal temperature. So those, you don't want to mitigate that. That's has a huge impact on closure. We're not just changing it because we want to change it. We're doing it because it needs to be changed, right? Peri-wound protection, I have a couple of things here, and again, I'm not advocating for any one company over another. I've got a couple of types of products that probably a lot of you have seen. One of them is no sting, and I better hold it up. And the other one is the skin prep, and this is just a no sting type of skin prep. Skin prep without this particular type, the regular skin prep, has alcohol. You put that close to a wound, it's going to burn. Okay, so it's still good protection. What these liquid film barriers do is you lay down some protection around the wound, you let it dry till it's tacky, increases your tape adherence so that your dressing actually stays in place. Press it down right around the wound so you don't get that migration of fluid that eats the surrounding tissue. And when you take the dressing off, the tape takes off this layer, not the skin. So it has some skin protective ability as well. But if you're in a place where you just need something to minimize moisture on the skin, you can use zinc oxide. You can use a multitude of things. But you need something around there quite often in order to have success with managing it. And if your skin is drying out and cracking from multiple layers of something like a liquid film barrier, Sween cream is a moisturizer that's available. It's not Sween 24, it's Sween cream that you actually take and you put a very, very thin layer, rub it right up to the edge of the wound, anywhere the dressing is going to adhere, and you can tape to that. And it's very protective. So packing. We're going to talk for a second about packing. I am assuming most of you use packing, but what I want you to think about is why. Why am I packing a wound? I'm packing it to avoid premature closure. So how I decide when I'm going to stop packing is when the depth of the wound is shallower than the width than the distance around. That to me just makes perfect sense. Is it likely to prematurely close if it's larger in diameter than it is in depth? Probably not. And packing can cause pressure. So you want to use something that doesn't form a knot that they're going to sit on. And trust me, I've seen packing, gauze packing stuffed in things that I swear did get tied in a knot when they put it in. Fluff it, don't stuff it. I always recommend Aquacel type ribbon packing because it turns to a gel, as I said, and it mitigates any increase in pressure. How often? Again, manufacturer's guidelines, but you can leave something like that extended wear product in for 2 to 3 days, as long as drainage allows for that. And you decide when to stop, as I said, when the depth is less than the diameter around. Packing is a foreign body. It will splint a wound open. So it's a good, when you can, you need to stop packing. So what about deep wounds? Do you irrigate something you can't see the bottom of? Better be very, very careful. How do you decide what's safe? You ask someone for an assessment of it. You have them do an MRI, look at is there any invasion into bone areas? Is there any issues with it going into any kind of organ space? And that's who you ask for future direction. You go back to that physician and say, with a gentle probe with a Q-tip, I can't find the bottom of this wound. I have no idea where it's going, and I can't irrigate it until I know the parameters. It's just not safe. So I know we think about dressings as a task, and I'm going to challenge you to think about it as more than a task. When we use a product, we're using it to actually help to close a wound. So don't change it according to standards that someone has set. Please engage with your physicians to allow the dressings, if you're starting to use some of the more advanced dressing products, and I know that now they are being covered in long-term care, you need to ensure that you're using them cost effectively and using them in the best way you can to get A, the most value for your money, but B, the best result. So when Penny alluded to the fact that getting a piece of pressure management equipment is expensive, the CAWC says that any pressure ulcer of any stage, the minimum cost to closure is $5,000. So if you're going to use dressings, it's fine for them to be expensive, but use them with efficacy, use them efficiently, make sure you read the research on them and ask somebody if you're not sure, because they can add up very quickly as well. No matter what dressing product you use, and there are no silver bullets. The VAC is not better than everything else. Silver, not everything needs silver. You need to find out what it is you need it and why you need it, what you need it for, but it has to be in contact with 2 inches of good skin. So if you're going to use this dressing, you can see how small it is. The wound is the size of my finger. You have to have 2 inches of this pad on skin in order to absorb that drainage, or that drainage will sit on good skin and make this wound larger. So it's absolutely essential that you don't be cheap. If you're going to use the darn thing, that you use something that's the appropriate size. And that's probably one of the most key principles. And the other thing is you can stick anything on anything, and it will not solve the problem if you don't look at the individual. So when I think about this, when I think about diabetic foot ulcers, which is an area I spent years studying, it doesn't matter what dressing I put on if their sugars are 18. It doesn't matter what I put on if they're going to sit on a hyperinflated cushion, right? So you need to manage the individual first to the best of your ability, but you need to manage their comorbidities. If they have COPD and they're on oxygen and they have a toe wound, what's the likelihood of closure? Do they have any oxygen going to tissue? You know, so practicalities are a really good thing, but we somehow have to try to manage those comorbidities, manage that pain, manage those other things. No dressing heals a wound. And when I do workshops, I often do it with the reps, and I'm sure they're ready to kill me, because I'll say, if you get it right, You can put toilet paper on a wound and get it to heal. It's not about the dressing, okay? It's about the person. So we need to think about infection, because infection is our worst enemy. When we have open skin, we've got an open portal for infection. So they can be quite insidious, or quite hard to recognize in chronic wounds when you're looking at it every day. So if something stops healing, if you're measuring and it's not progressing and you're doing all that you're supposed to do, absolutely look at swabbing something. Think about new breakdown. Has suddenly it gotten larger? Has the drainage changed in some way? Has it turned color? Has it gotten to be, is there more of it? Is there erythema? Is there redness around that wound? And again, measure that edge. Is it advancing? Is there edema? Is there swelling? Is there a smell? And when I talk about the smell, it's not the smell of the dressing. If you use hydrocolloids, they absorb a ton of malodor. What you want to do is you need to take the dressing off of the wound, clean it, get the dressing away from your nose, and does the tissue have odor? And if it's easily, if it bleeds easily, so you're cleansing that wound very nicely, you spray it, you dry only the edges, you do not scrub, nice new granulation tissue, but you just barely touch the edge of it and it bleeds. Friability is an indication of infection. So those are all things to think about, and those are all indications, because they don't jump up and say, I have a problem. And you have to look at multiple things. So it's not usually just one thing, right? You're usually looking at, is there a red edge? Is it really friable? Or has it stopped closing? Okay, so those are some of the indicators. And then what we want you to think about doing is culturing that wound. So wound cultures are really hard to get the lab to process. And then one of the reasons for that is because we don't give the lab enough information. And I did some research on this, so I honestly know that. Because I wasn't giving them enough information. What they need, if you're going to swab a wound, you need to say why. You need to tell the lab where the wound is, what has happened that you think it might be infected. So the drainage has increased, it has an advancing edge, it has an advancing erythema, there's increased pain, and they need to know that on the rec. And then you must cleanse the wound before you culture it. So you spray cleanse it really well. You take one of those lovely star swabs and you put on a sterile glove. You have to do it. And you have to grab it about 2 inches from the end of the swab, because that, those are very flexible. Little Q-tip thing. I grab that with the sterile glove, I insert it into the center of the wound, and I actually rotate it and dig it a little bit into tissue. You need to get a good sample of that tissue in order to get a culture. And then what you're doing is you're sending that for culture and sensitivity, so that you're not cultivating things that are, you're not advocating for anything that's going to cause resistance. Now the lab can do culture and sensitivity testing, and they can send those results to the physician, where he can actually have an antibiotic, he or she can actually prescribe an antibiotic that's going to work. So the culture is important to the ongoing antibiotic management and reducing the likelihood of resistance. So it's really important, if we send it with all that information, and that we have a discussion with our local labs so that we get what we need out of it. So all the things that can influence healing, and there are many, and this is probably the short end of the list. Nutrition is a big one, and I already mentioned Canada's Food Guide. If you have access to a dietitian, they can be your best friend. When we had our wound care resource team was developed in Saskatoon Home Care, our dietitian got involved, and she was a fabulous resource. And what I would do is I would go out to clients and I would say to them, because I was consulted, I would go out to them and talk to them about all of the things going on in their environment. And then the one lady I remember going to see had severe rheumatoid arthritis. Well, if you know anything about people with arthritis, they have a fairly high tendency of things like having ulcers, lots of gastric symptoms. So I said to her, you know, her and her husband, I said, I don't want to insult you, but you've had this wound for a really long time, and I think you probably need some extra nutritional support. And if you don't mind, can I ask a dietitian to come and see you? And they said, yes, actually, they've been trying to get a dietitian to come out. And then I would say, well, can you write down whatever you eat for the next few days? And when she gets here, then she has some information. So she doesn't want to pick your diet apart. She doesn't want to tell you that you're not doing things right. What she wants to know is, can you eat nuts? Are you a milk drinker? Why do you think those things are important? They're protein sources. We need to know what proteins they can eat and what she can facilitate an increase in. So she will look to their food likes and dislikes, and she will streamline a program for them around that. And that's what you need from your dietitian partners. The medications are on. We talked about steroids thinning the skin. NSAIDs, when you initially have a traumatizing injury, the first phase of healing is inflammation. And if you have a normal inflammatory response, you can progress through to healing. But if someone's got arthritis and they're in long-term NSAIDs, are they going to have inflammatory response? Not very good one, because they're on non-steroidal anti-inflammatory drugs. So we need to consider all those things impacting on chronicity. Medications like warfarin that cause bleeding, medications like steroids I mentioned already, chemotherapy. Cells do not divide when people are receiving chemotherapeutic agents. If they're on long-term methotrexate for rheumatoid arthritis, are they likely to actually grow tissue? Not very efficiently. We need to recognize that those things are influencing our results. Local blood supply. If you're looking at someone's foot that has a wound on it, please palpate the pulses, do the caps refill. If they don't have blood flow, what's the likelihood of healing? It's amazing though, sometimes we negate to think about some of those things. Infection. I talked a bit about recognition of infection, but infection can be something that's not well recognized in things that are people that are on NSAIDs. Again, no inflammation. Do you have far more difficult to recognize infection in those individuals? One of the first indicators of infection in diabetic foot ulcers is pain in an insensate foot. So infection causes pain. If there's something different, we need to recognize it. Comorbidities, those all influence healing. I mentioned the lack of oxygen if you've got COPD. What about if you're anemic? Hemoglobin is a source of oxygen. What if you smoke? What if you are taking, other things like hypertensive drugs that actually minimize some of that peripheral blood flow, cause vasoconstriction? Patient adherence. And Penny alluded to that when she talked about the gentleman who had his cushion overinflated all the time for his comfort. We can do all that we like. What we need to do is educate our residents in order to have them recognize why we ask them to do what we ask them to do. But at the end of the day, if they're in control and have choices, they don't always make the best choices. We need to recognize that, work with them to try and modify some of those behaviors. And local wound care. More damage, I think, is caused sometimes by the use of inappropriate cleansing. Making sure that when people are going in showers, I had this brought home to me in spades one time when I was we did a prevalence study actually in Saskatoon home care. It's quite a unique experience. And I went out to see a very large gentleman with had wounds in his groins. Actually, I think at the end of the day, they were pressure ulcers because of his large pannus. But he would sit in a recliner chair. He he was only being seen every 2 weeks. So we walked through, what do you usually do when you're cleansing these wounds? Because obviously he's self-managing. And what he said to me is, I get in the shower and I don't put the spray on really hard, and I cleanse those areas really well. And then I take a towel, because they told me, some of the problems I'm having is because of too much moisture in those, in the groins. And I scrub that area with the towel to get it really dry. And I looked at him and I said, you, I think, are taking off any new tissue growth every time you dry those wounds. So feel free to get in the shower and clean them. That's great. They look nice and clean. Everything looks to be really good. They're very superficial. But then just take that same clean towel, tuck it into those groins before you get out of the tub, just to take up that extra moisture, and then put the dressing on. made a world of difference. The other thing I did is you've got pressure management issues, so he sits in a recliner chair, and what do you do all day? Well, I watch TV, and I said to him, well, every commercial on the TV, about every 15 minutes, I want you to shift your weight. You get up, you go to the bathroom, you get up, you get a drink, you put the chair back, you put it forward. That's pressure management as well. So those are things that we can do at a local level. Stress, I mentioned, insomnia is a source of stress. Pain is a source of stress. So those things are our control over people's life is a source of stress. So if we can somehow mitigate some of the stress, if we can do the dressing at a certain time of day because it's more suitable for them, that might help things to heal, because stress is directly related to increased risk of infection. So wounds are extremely socially isolating. If you walked around with something that smelled, can you imagine wanting to go out in public? It was a very interesting study. I actually went to Wales and did a master's in wound healing, and one of the professors there was a psychologist. And you think, really? A psychologist in a wound healing unit? But you know, she did some research on little British ladies that were wearing what they call Charing Cross or Pro-4 dressings. So they're 4-layer compression wraps, because that was the mode of managing venous leg ulcers at that point. And they would go, and it's very predominant. Venous leg ulcers are quite predominant in the British culture. And these women would go out, very prim and proper British ladies, and these dressings on their legs, and they would go to get their groceries, and dogs would flock to them. Do you think you would want to go out in public if the dogs all came to you? No. Wounds are very, very socially isolating. I've had people that the wounds smell. I had one lady I went out to see outside of Saskatoon, and they said to me, you know, she's had this wound for 25 years. She had had a sarcoma removed from her hip. She had had radiation when they didn't know how to radiate well. They over-radiated her tissue. She didn't have a wound. She had severely damaged skin that was in the shape of the graft that had been put on post-sarcoma removal. And when I went out there, she had reacted to every kind of tape and dressing. She was sensitive to everything that they could possibly put on it at that point. So they took a pin and they pinned an ABD to her undergarment to cover it because it was draining. And when I got there, I found out that she had not been out of the house in all those years because of the smell. And what it was that skin had trapped all kinds of bacteria in the furrows of that very damaged skin. So what we did is we cleaned it, shocking, put some metronidazole gel on there. So the flagell, powdered flagell, if you pulverize flagell tabs, they'll also manage odor. Sprinkled that on. Actually, we had now had brand new products that she wasn't going to probably react, and we could patch test her to test for allergies on her arm or somewhere else. Covered that up with a foam, put a foam on and covered it with Opsite to seal the odor, and she went out and played bingo for the first time in 20 years. So, I mean, they are very socially isolating. We need to educate the people around us. If the resident isn't capable of absorbing the information, we have to engage their family because they're part of the parcel of the team. And so we really need to think about, how does this impact their life? How can we make their life better? Is there anything we can do in our practice to actually enhance their quality of life? And one of the things we can do is actually get the other parts of our team involved, the other individuals involved. So we've heard from an occupational therapist, but immobility is what causes pressure ulcers. So if you have a resident in one of your homes that was up and mobilizing and that suddenly gets the flu and ends up in bed one weekend, the very likely outcome of that event could be a pressure ulcer. And in fact, they can develop very quickly. They can develop in very marginalized individuals within 24 hours. And in fact, I was introduced to the long-term care facility I currently consult to when one of their individuals with dementia, very severe dementia, developed 5 pressure ulcers over a weekend because for some unknown reason, I think he was brought out to the dining room in his chair, Remember I said to you, if you have dementia, you don't respond effectively to pain stimuli. I don't know if he was expressing pain in another way that was unrecognized. But by the end of a day or so in that chair, he had 5 pressure sores. And one of these horrible areas of black esch are both ITs, his coccyx, and I believe both his heels. And one of my first comments to the nurse practitioner in that home was, how close is this person to the end of life? Because when you have that marginalized skin, your skin is the last organ to go. And so he was actually very palliative. That's not an excuse, it's the way it is. But immobility is a source of pressure. And if people can't move, if they don't have the ability to tilt their chair, if they don't have the ability to get out of it, they will develop pressure ulcers. If all of you sat here and were immobile for this entire time, you'd be getting pretty red by now, honestly. So we need our physiotherapy partners. Because even if I'm sitting in this chair right now and all I can move is my head, tilting my head forward, if you do that, sit in your chair, sit straight up, high on your ITs, and tilt your head forward, there's a slight reduction in pressure on your ITs. Put your head to one side. Put your head to the other side. Marginal movements actually minimize pressure. When you're talking turning and positioning, and all the surfaces in the world don't negate the need to turn and position people. I don't care if it's got a fancy motor, it doesn't do it. Okay, you still have to turn and position people. And you really need to think about, so one of the things you need to think about is there any source of pressure under this individual that I haven't looked to? We need to be moving people around in the beds. We need to try and increase that mobility somehow. Occupational therapists, we've heard, are a phenomenal member of the team in helping us figure out how to help with pressure management. That's only a small component of their workload, but at least it will help us. So if you have someone who's suddenly got more issues, have the OT review that situation. There's probably something in their seating or the surface that they're on that they can enhance. And I mentioned dietitians. They're integral to the team. So that interdisciplinary team model, this is called holistic care. And the team member that's the most important is your patient. They're at the center of your team. The rest of us facilitate them. And that's the gold standard of prevention and management in wound care. And it's when you are working in your own facilities, you need to look at who are my team members? Who do I have? Who's in the facility that might be able to help me? Is there a dietitian? Is there an occupational therapist? Is there a physiotherapist? If there's not, the squeaky wheel gets the grease, and we need to identify why those members are necessary. But is there a way of having them interfacing with them through another medium? Technology is fabulous. Can you use Skype? Can you use FaceTime? Can you use telehealth? Can you have the OT help you assess a cushion underneath somebody? I'm going to challenge you to think about that, because interdisciplinary teams can be virtual, right? But honestly, you guys can do it. Prevention of wounds is a huge challenge in a very marginalized population. And it's a challenge for all of us that we really need to try to step up to.